ladies and gentlemen, I'm Dr. Silva. Thank you for joining me for this talk on why your antidepressant isn't working. Many patients, particularly treatment-naive individuals who are new to taking psychotropic medications, often report that their medication isn't working or not as well as they had anticipated. So this video is going to cover the most common mistakes and misconceptions patients make when first taking prescription psychotropic medication. A lot of times patients will get ahead of themselves, and that's probably the most common reason that we get a complaint early on, particularly from neophytes, people who have never before taken psychotropic medication, and that's that the medication hasn't been taken for a long enough period of time. I think this is probably the most common reason a medication doesn't seem to be working after starting taking it, and it's simply a matter of expectation. Early on, the medicine simply hasn't had enough time to work. Although in a minority of cases, a person will begin feeling better within a few days, I've seen this with, well, I shouldn't say in a minority of cases a person will begin, I think most people begin to feel better within a few days, but people don't necessarily reach a significant amount of improvement. And certainly if we're talking about remission, that doesn't happen for a couple of weeks usually, sometimes a month, sometimes a little bit longer. Depends on the target symptoms. So if we're talking about anxiety, that can take, for the full effect, that can take several weeks, a couple of months even. Whereas if we're talking about irritability, that gets better overnight. That gets better with 1 or 2 doses even. So most patients will begin to feel better within a few days, significantly better within a week or two. And then with some of the dual acting agents, the SNRIs, such as Effexor, for example, I've seen a number of times that patients get significantly better, like almost to where we're going to get within just a few days, 3 or 4 days. And that's especially true in individuals with moderate to severe symptoms that are largely due to endogenous, i.e. physical depression. Those patients that have more severe symptoms that are going to get a more robust response anyway because they have a chemical imbalance and they really need the medication. They have an absolute need for medication as opposed to just a relative need. And so a lot of times those individuals get a whole lot better, and they do so very, very quickly. But it's more standard for a person to appreciate only mild side effects initially, because those notoriously will show up right away. There are some side effects that don't show up until later that are dose dependent. So until we reach a certain threshold, you're not going to experience those side effects. But most side effects are immediate as opposed to the beneficial effects. This is particularly true in psychiatry. And so a lot of times for the first days to weeks, all you have are side effects. And then you begin to see gradual improvements. In fact, many times, just as most of the side effects are beginning to disappear, the therapeutic effects begin to kick in. And again, I could say that if it's dosed properly and if a person is taking it in a judicious way, you can obviate most side effects. But then the ones that you are left with, they actually get better also pretty quickly within a few days. But a lot of times, some of the more stubborn side effects that take a little bit longer to get better do start to fade just right around the time that you begin to see the beneficial effects kicking in, really kicking in. So it's definitely worth sticking it out until this occurs. Even in those individuals who begin to feel better right away, the full effect of an antidepressant medication can easily take 2 to 4 weeks or longer to manifest. Considering that many times the starting dose will have to be titrated, i.e. optimized by increasing it a few times, depending in part on how the person is tolerating and adapting to the side effects, it could be 6 to 12 weeks or longer before just the right dose has been taken for long enough for a medication's full benefit to become apparent. So patience is key. That said, in the vast majority of cases, you should begin to see noticeable improvement in your symptoms well within the first month. What can you do in the meantime? Well, one thing your doctor can do is to prescribe other short-term medications designed to address certain target symptoms while you're waiting to feel better. For example, if insomnia is a prominent symptom of your depression, once your depression is better, your insomnia should self-correct, especially middle and terminal insomnia. So not so much trouble falling asleep, but waking up a lot in the middle of the night or waking up in the wee hours of the early morning and not being able to get back to sleep. those are textbook symptoms of, again, endogenous depression or anxiety. But until then, you can take a sleeping pill and then hold it when you no longer need it. Or, for example, if you're taking a quote-unquote antidepressant, SSRI medication such as Prozac, Zoloft, Paxil, Lexapro, that's actually being prescribed to you to treat the symptoms of panic disorder, rather than allowing you to continue to experience panic attacks while you wait for the SSRI to take effect, panic can very effectively be blocked in the short term with what we used to call quote-unquote minor tranquilizers, such as Valium or Klonopin, benzodiazepines, while you wait the several weeks for the SSRI to begin working on that particular symptom. Anxiety takes a lot longer. And by the way, we called them mild tranquilizers to differentiate them from the quote-unquote major tranquilizers, but it's curious because they're two completely different kinds of medications. Benzodiazepines and conventional antipsychotic drugs like Haldol and Mellaril, those old dinosaurs that we call the major tranquilizers. And they were tranquilizing, but they're really totally different kinds of medication. We don't use that terminology anymore. It's important, however, not to get too attached to these temporary quick fixes, these band-aids, because in the long run, you'll be much better off with the standard daily dose of the non-addictive medication that's best indicated for your condition, rather than taking pills on an as-needed basis. Pills that work quickly, but typically not for long, and which are usually habit-forming. In fact, sometimes the early quick fixes actually sabotage the treatment plan, especially in individuals who are prone to substance abuse. People get attached to them and then they don't care about the gold standard treatment. So be sure to have an open and frank discussion with your physician if you begin to lose faith in the actual recommended treatment with its early side effects and modest gradual gain in favor of the sedatives and tranquilizers, especially if you feel you're at risk of becoming, if not physically addicted, at least psychologically addicted to those early, immediate remedies. Over-reliance on them may leave you quite disenchanted with the gold standard treatment, which works by a completely different and ultimately superior mechanism, and which can't compete with the feel-good drugs. Now, that's not to say that I don't often continue a medication for insomnia or even a medication as needed for high anxiety in a patient that has begun to receive the benefit from the gold standard medication. But as far as taking medication during the day to ward off panic attacks, if the gold standard medication is working properly, then the need for that type of medication should really diminish and veritably disappear. And in fact, I often use that as a gauge to make sure that our treatment is proceeding the way that we anticipate that it should be proceeding. Number 2, the medication is not being taken properly and or consistently. That is, doses are being missed, and this is easy enough to do, especially if your regimen requires you to dose more than once a day, or with complicated regimens that require starting at a low dose and then adjusting the dosage on your own before you see the doctor again. Mistakes can be made there, so if you're not used to taking medication, you can simply forget to take it. Or if the titration schedule is complicated, you can become confused as to how and when to increase your dosage. So sometimes I'll have patients come back and they never increase the dose. They misunderstood, even though the bottle, they'll say, always check your bottle. But that's another very common reason why patients come back and they say, it's not working. And it's because they didn't adjust the dosage or they're not taking it every day. With psychotropic medication, you have to take it every day. You have to be very consistent with it. And some people just are not very good at taking medication. So I tell those patients to get a med minder. That way, if you can't remember whether you took your medicine or not, all you got to do is look. It's one of those little boxes with the days of the week, and it can tell you, and particularly if you're expected to dose more than once a day. I really try to avoid that. Most psychotropic medication can be taken once a day. As far as effectiveness, it really doesn't matter what time of the day that you take your antidepressant, and you don't even have to take it at the same time every day, but you do need to take the full dose every day. And at the beginning, it probably is a good idea to take your medication at the same time every day, just so you can minimize your side effects and so that you can get to steady state. You won't get to steady state any faster, but those first few doses when you're not at steady state, usually it takes 5 half-lives to get to steady state, then you're going to get more fluctuations in your dosing, and especially more fluctuations if one day you take it in the morning and the next day you take it at night and then you take it in the morning again, so it's not even 24 hours later, it's like 12 hours later. So you want to pick a time of the day and stick with it in the long run, not for efficacy, not because the medication is going to work any better, because once you get to steady state, you're at steady state. And so your medication, the drug levels in your bloodstream are fluctuating at a minimum anyway. But it might also help you to remember, if you're always taking it in the morning or you're always taking it in the evening, sporadic use will diminish the benefits or even prevent any benefit. And with some medications, and with regard to certain symptoms such as anxiety and irritability, erratic dosing can actually lead to rebound symptoms in which you do worse. Get a MedMinder or other medication dispenser. You can find them at any pharmacy. With regard to medication regimens that change over time and that you need to ramp up or down between doctor's visits, make sure you ask your doctor to write down the dose adjusting schedule in complete detail, especially if you're being given free samples and so you don't have a prescription bottle to refer back to. When in doubt, call the prescriber's office and ask for clarification. The dosage is too low. For a variety of reasons, sometimes a patient will languish at a dose that's subtherapeutic, and whether it's the doctor's fault for not increasing the dosage when necessary, or whether the patient doesn't return for their follow-up appointment in a timely manner, many people derive little or no benefit despite compliance with their treatment regimen because they're simply not taking enough. Sometimes an individual will do very well on a starting dose, and months later, when they're feeling symptomatic again, they don't realize that the medication has stopped helping. Be mindful of medication quote-unquote poop out. This is seen with Prozac and other SSRIs. A simple and modest dosage adjustment is typically sufficient to regain a positive response, and this doesn't mean that the medication will have to be increased in this manner indefinitely, that you're going to have to continue to do this. But what also might happen is that the medication might stop helping as much, and it may take you a while to realize that, it's not working as well as it was. And you may not realize that until you get back to your psychiatrist and start talking to your psychiatrist about it. And so that can be a little bit more subtle, but that also indicates that a dosage adjustment is warranted. And particularly if your physician parks you at a relatively low dose after you get that honeymoon period where things get a whole lot better initially, and you fail to titrate to an adequate dose that's going to maintain you, you could actually get that loss of efficacy sooner rather than later. Untreated substance abuse is interfering with treatment. Abuse of alcohol and other recreational drugs will certainly sabotage your treatment. Often patients aren't completely honest with their healthcare provider, especially if they're new. Perhaps they feel embarrassed or ashamed, or maybe they're in denial, or they're not yet ready to give up their substance use. That's usually the case. Obviously, if you're smoking crack on the weekends, you are. But a lot of times, patients can be really irrational about it, and they're continuing to use cocaine, but then they come back to their doctor and they sincerely complain, this medicine isn't helping. It's not helping my insomnia. It's not helping my anxiety. And it's like they compartmentalize. And even though they know better, if they really looked at it, if they examined it logically, but it's not that they are lying to themselves even. It's just that they compartmentalize, and they put that on a shelf. They want to use their Coke. They love using Coke. They only use it when they go out on weekends, with their friends, which is like every weekend. And they're only snorting it, or whatever rationalizations, whatever other defense mechanisms they employ. And then they lie to their doctor about it because they're certainly not going to tell their doctor, right? They don't trust their doctor yet, or they don't want to get in trouble. And so they come back with sincere complaints to their doctor, fix this. And the fix is stop using cocaine. And they honestly don't put two and two together. But if you truly don't have a drinking problem, then removing alcohol from your diet should be no problem, at least during the short period of time where you're trying out a medication and for the first time, when you're starting to take a medication. You should be able to stop drinking alcohol for 6 weeks or a month. People who really can take it or leave it can take it or leave it. Right? You can always resume quote unquote social drinking later. when your mood is all better, and when we know that this medication works at this dose and we're good to go and we're on maintenance treatments, we're on autopilot. On the other hand, if you find it a challenge to forego drinking, even for a few months, then you should seriously ask whether you're being completely honest with yourself. Even if you don't believe that you suffer from chemical dependency, if you're having mood problems and the physical problems that go along with that, i.e. a sleep disturbance, appetite, energy problems, difficulty concentrating, problems with your libido, etc., then taking a break from any and all other mood-altering substances before embarking upon a psychotropic medication trial almost goes without saying. And certainly for depression and anxiety, alcohol is detrimental. Whether it's a little bit or a lot, alcohol is a poison. I'm not saying that metaphorically. Metaphorically, yes, as well, but also literally. It is the only alcohol that is non-poisonous in moderation when you compare it to isopropyl alcohol or methanol, wood alcohol. That won't kill you in moderation. And that's in moderation. Alcohol will definitely kill you if you drink enough of it. Alcohol poisoning can kill you. But because it is a poison. And I'm not being preachy. I'm not saying that I am a teetotaler. I'm just saying if you're depressed and you're anxious and you're not sleeping and you have no sex drive, hold it for a while. In some cases, just laying off the recreational drugs for a few days or a couple of weeks resolves the depressive symptoms. There is such thing as substance-induced mood disorders. Even a moderate use of alcohol can confound your new medication trial. Besides, if you're tired all the time and you're not sleeping well and you're irritable and your mind is full of negative and depressing thoughts, alcohol is contraindicated, whether or not you choose to submit to a medication trial. And if you think that, quote, alcohol is the only thing that makes me feel better, I've heard that plenty, then you really have something to discuss with your physician and possibly your therapist. Psychological factors are overruling biological factors. Sometimes medications don't, quote unquote, work because the problem is not primarily a physical one, a chemical one, even though you may be experiencing plenty of physical symptoms because you're not sleeping well or eating right, or stress is giving you headaches or indigestion, etc. If your central nervous system is functioning within normal limits, despite the presence of these physical symptoms, and your unhappiness has more to do with your environment, an unhappy marriage, a job that you just hate, etc., medications may not make much of a difference if you don't also address the specific stressors in your life. That includes, and perhaps especially, personal relationships and work and school responsibilities. Those are always at the top of the list. That said, the SSRIs, Prozac, Zoloft, Lexapro, and really serotonergic medications in general as a class, so including the SNRIs and, for that matter, tricyclic agents and the newer multimodal agents, as long as they increase serotonin, they can go a long way to block stress reactions, such as crying spells, feeling overwhelmed, panicky, angry outbursts, obsessing about your problems, dwelling on the past, worrying about the future, etc. Those symptoms are specifically responsive to serotonergic pharmacotherapy. So even in situations which have more to do with difficult life circumstances than with unhealthy brain chemistry, a brief trial of a medication can help. Not Wellbutrin, though. You have to take the right medication. It has to be a serotonergic medication. And if there's a lot of anxiety, if there's a lot of stress, I wouldn't recommend mirtazapine either. Mirtazapine, Remeron increases serotonin, but not by reuptake inhibition, and it's not as good as medications that have that as a mechanism of action for increasing serotonin. So even if your diagnosis is an adjustment disorder, if it's an adjustment disorder with anxiety or an adjustment disorder with depression, but that also includes a significant component of anxious distress, you really want to consider, especially if you're not sleeping and you're dwelling, you're having these physical manifestations of. So there's nothing wrong with your genes, and ordinarily you have enough serotonin, but now you need extra serotonin because you've got this big problem and you're worrying about it all the time, and you're really obsessing about it. And so you don't have this because of something you inherited from birth. It is because of a huge problem that you're having, but other people might not be obsessing about the same problem, and you are. And so ultimately, you could argue that it does harken back to your temperament, to your constitution, and to your genes. It's a spectrum. I believe that mental illnesses, they all lie on a spectrum. We're all human beings. We all feel emotions. We all have emotions that are too negative and too intense. And whatever our individual threshold is for experiencing those emotions, most of us, the vast majority of us, could use a little help from time to time. Whether that's pharmacologic or non-pharmacologic, we all need to be living our best lives with regard to diet and exercise and sleep and that sort of thing. Some people, though, have very low thresholds all the time for intense dysphoria. Those people have diagnosable conditions, but we're still all on the spectrum of feeling good to feeling miserable, depressed, anxious, angry. We just have different thresholds for it, really. So if you're having severe stress, a brief trial of medication can certainly help, even if your symptoms are primarily due to a reaction to exogenous stressors, especially since severe stress induces psychosomatic changes, including in the central nervous system, that can lead to self-sustaining illness. And so the line between what's externally caused and what's internally caused becomes blurred and irrelevant. If you do choose to see a psychiatrist, the aim is for medication to reduce specific symptoms called target symptoms, enough to help you feel better cope with the situation in the short term, and to make necessary changes in the long term. But make sure that you and your doctor have clearly set out what those target symptoms are, and don't forget to involve your support system and to consider counseling and other professional services as appropriate. This way, you'll only leave the target symptoms to the medication, and you won't neglect to address everything else that needs to be addressed. We need to be well-rounded in our treatment, just as we need to be well-rounded individuals. So you want to address the medicinal and the non-medicinal to come out of your depression and anxiety, regardless of what the ultimate source of it is. Some target symptoms will be completely addressed by medication, while others will improve with medication, allowing you to continue working on them with cognitive and behavioral strategies, including lifestyle choices and psychotherapy. If dissatisfaction is significant enough, medication by itself obviously won't solve your problems, and by adopting this holistic approach, you'll be less likely to be disappointed that the medication isn't helping if psychological factors outweigh physiological factors. Okay, now this is in the instance where psychological factors outweigh physiologic factors. Because if you flip the script on that, when physiologic factors far, far outweigh the psychological, when there is a problem in the central nervous system and you are very sick physically, the way that you perceive your life and the world is colored by that illness, such that you might not be able to do psychotherapy until we get those medications in hand, because there's just too much physical illness going on. So sometimes you can't do that well-rounded holistic approach until you've started medication. And then as you begin to feel better, then you can attend to those non-medicinal variables. And then for some people, if it's really on that end of the spectrum, then all you need is medication. All you need are pills. For some people with major depression, all you need is medicine, because once that chemical imbalance is fixed, you don't need to go to therapy, because all of those negative thoughts and all of those, even sometimes quasi-delusional or delusional beliefs, they're gone. And so you're fixed. You don't have any symptoms, 0 symptoms. You're back to your baseline. So it has to be looked at on a case-by-case basis. It's different for everybody. These are generalities. Other medications or medical conditions are interfering. Very infrequently, there may be other physical reasons why you're not responding to antidepressant treatment the way you should be. but these reasons tend to be limited to certain physical aspects of your condition. Sleep patterns, pain thresholds, energy level, appetite, for example, and not necessarily to more mental, global processes such as your overall outlook or your ability to cope. One notable and not uncommon exception would be hypothyroidism. Endocrine hormonal problems in general can have a profound mood-altering effect and should be ruled out in patients in whom they are suspected. Check with your doctor. Thank you for listening.